I'd like to thank you all for joining the League of Women Voters of Lexington's First Friday Forum on COVID-19. My name is Charles Hornig. I'll be managing the technical aspects of this Zoom webinar. First, a few housekeeping matters. This webinar is being recorded for later viewing on LexMedia. We will be using the chat function only for technical issues. For questions, we'll be using the Zoom Q&A function. So if you have a question later in the presentation for the panel, use the Q&A function. I'll be reading out the questions to the panel and they will be answering them live. We will not be using the raise hand function, will not be taking live questions, spoken questions, just written questions. If you do have trouble with your audio, check your computer volume. If that doesn't work, you can also connect to this meeting via telephone. And the phone numbers are shared on the screen there now, and they are in wherever you found the invitation to this. Finally, I'd like to introduce Eileen Zalisk of the Lexington League of Women Voters, who will be moderating this session.
Hey, thank you. Good morning, everyone, and thank you for attending this January 8th, 2021 League of Women Voters First Friday COVID-19 Lexington Area Update. My name is Eileen Gordon-Zalisk. I'm on the board of the Lexington League and was involved in planning this program. I want to begin by thanking the League of Women Voters, Charles Hornig for helping with the technical Zoom aspects, and Margaret Copey, who's the league convener, who is here somewhere. Of course, I'd like to thank our guests, Senator Cindy Friedman, Dr. Matthias Waltz, and Casey Mellon, who are here also. Before we begin, a few quick league announcements. The next First Friday is going to be February 5th, 2021 at 9:30 a.m. It's exactly a month from today via Zoom. Carol Rose, who's the executive director of the ACLU Massachusetts, will be doing a post-2020 election review. Also on Thursday, February 11th, 2021 from 7:30 to 9 p.m., the League of Women Voters is going to be presenting a candidates night for our local election via Zoom. The topic today is, as we said, COVID-19, a Lexington area update. This past week has been the deadliest since the beginning of the pandemic. On Wednesday, a record 3,915 people died of COVID across the United States, the deadliest day of the pandemic that has already claimed more than 360,000 lives across the country. Yesterday, the Massachusetts Department of Health designated 219 cities, some of them in our area, which is Senator Cindy Friedman's area, as high risk for coronavirus, putting nearly 2/3 of the state's 351 communities in the red category. There were 7,136 new confirmed cases and 71 deaths yesterday. The 7-day average of hospitalized patients was 2,386, up from 2,208 a week ago. There were 455 patients in intensive care. So what is the state of COVID-19 in the Lexington area at this time? What do we now know about how to prevent, identify symptoms, test and treat the disease? What has been the state and local government response? What do we know about the new variants of the COVID-19 virus? What are the plans for vaccine distribution? These are some of the questions that we hope to answer today. Our format is the following. Each of the speakers will talk for 5 to 7 minutes and a little longer if they feel they need to. And then we will have questions and answers. As Charles will be curating and reading the questions and answers that you post in the chat. Please indicate who your questions are directed to, although we hope that all of the panelists will feel free to respond to any or all of the questions. The first speaker is Cindy Friedman, Massachusetts State Senator for the 4th Middlesex District in Massachusetts. That district is Arlington, Lexington, precincts 1, 2, 4, 5, 6, and 7, Burlington, Billerica, and Woburn. And she's going to speak about the state government legislative actions, and district-wide issues. Cindy?
Thank you, Eileen, and thank you for inviting me to speak today on this very important issue. I know this is one of the most important and pressing issues that we have before us right now. So I'm happy to be here. And I would just also like to thank Dr. Walls and Casey for being here as well. I'm going to talk about the state, what we've done as a state in terms of the response to the pandemic, but you also have here people who are equally as important and as involved in caring for our residents and keeping us safe. We all know and acknowledge and value what Dr. Walls has been doing and what the entire medical profession has been, especially in our hospitals who've been hit so profoundly. And we can't overstate enough how important and how meaningful what they have done and are doing has been to keep us all safe. And we also need to acknowledge the incredible work of our local boards of health. Because while our hospitals and first responders take care of the people who are sick, it is our local board of health who have the responsibility and the burden to keep our community safe and to implement a lot of what the state is asking to have happen. The local boards of health are the people who are going to do a lot of this work for our community. So I cannot state enough how important their role is and thank them for all that they are doing. And thank you, Casey. I'm very lucky to be the senator of the 4th Middlesex because we have such a profound and robust medical system, medical providers, local boards of health. All of these people are integral to making this successful and keeping us safe. So having said that, I'm going to now talk a little bit about the state's doing, and I'll do it briefly so that I can, there's times for questions. So I'm going to focus on this. I am the chair of the Senate Committee on Healthcare Financing. I also sit on the advisory board for vaccines, the state advisory board that was set up for how to roll out and how to communicate the rollout of the vaccine. So I have I'm going to be talking about this from a healthcare perspective. So the first thing that we did, the first thing that the state did was set up a command center for COVID. And we did this in March. And this is really critical because we immediately put a structure in place that basically had one person to go to, one entity where everything was channeled. All of the water coming out of the fire hose went through one place. And this was really critical because there was at least a structure that allowed us to keep as cohesive a response as possible. And if you don't think leadership matters, that is a true testament to why we need leadership and how leadership can stand up and play a critical role. So we established the command center. And then there was a COVID-19 working group to centralize the pandemic responses. This was really important. The Senate also had a COVID-19 working group that was a bipartisan group of which I was part of, so that all of the things that the senators were hearing from their constituents also had a single point of communication so that we could roll that up to the administration to make sure that there was a clear communication and that everything was being passed on that needed to be passed on. Several public health orders were put in place right away through executive order. And this was, including the face covering, social distancing, prohibition of large gatherings, shutdown of certain businesses. These were immediately put in place and continued, and very, very important to keeping us all on the same page. We took a number of measures to require increased COVID testing and hospital surge capacity. The hospitals on their own and together shut down all elective surgeries a little before the surge came in, and so they were better prepared to take the increasing and very large number of people who were sick and needed to be hospitalized. And we also have increased over time testing capacity. There's Stop the Spread sites that anybody can go to. We worked with, the state worked with CVS and the pharmacies and other, urgent care facilities to make sure that their testing increased. We didn't have enough. We don't have enough, but we certainly increased our capacity enormously. We put an insurance coverage mandate in place that said all insurance, no copays, no deductible for people who need testing or inpatient or outpatient care because they have the virus. We expanded, and this is probably one of the most important things we did, we expanded access to telehealth. And this really, and coupled it with rate parity. So providers got the same rate for their services, whether it was inpatient or whether it was in person or whether it was through telehealth. This kept our system going. This kept our medical system going. It was nothing short of extraordinary and life-saving. We instituted nursing facility reforms. As everybody knows, nursing facilities were hardest hit by COVID, and the state stepped in with a new set of requirements and more money for long-term nursing care, as long as they met the requirements, which had to do with infection control and following the guidelines of the CDC and the medical profession. We provided $1.6 billion in state funding for our community hospitals, for all of our hospitals. This was through accelerated payments and also increased payments for Medicaid patients. Very, very important to keep our community, especially our community hospitals, solvent so that they could continue to serve their communities. We provided legal protections for healthcare workers and facilities. This is something really important. The Senate pushed this very hard with the state. And what this is that we needed a workforce, and probably Dr. Wells will talk about workforce, but we needed all of the workforce that we could get. We needed them to come back to our hospitals. And this included people who'd recently retired. It included people from out of state. And so it was really important so that they could start practicing very, very quickly, that they had legal protection. And so the state provided this legal protection so we could get more workforce, more providers and healthcare professionals into the system. We created a COVID-19 community tracing collaborative, which, as you know, did a lot of tracing to try and mitigate the spread. And then we directed DPH to publish a daily COVID-19 public health data, and that is the dashboard that we all have come to depend on, and was and is a key tool for getting information out to people. So that's kind of what we did in the COVID-19 space. We now are in the vaccine distribution, and I'll just tell you that the state, using CDC guidelines and the National Association of Science as well, came up with a vaccine distribution plan by phases of how we would roll out this vaccine. Phase one included all of our healthcare workers, our first responders, long-term care facility, rest homes and assisted living, home-based healthcare workers, and healthcare workers doing non-COVID facing care. So the mantra and the context for how these phases were developed were to save lives and to ensure that the people who were saving lives were protected first. It was to mitigate death. And so using that mantra, using that context, that's how we determined what the phases should be. So the first phases make sense, right? The sick people who are sickest and the people who need to take care of the sickest. And that phase is sort of around it started in December and probably will go through around February, right? And again, everything we say, everything I'm saying is completely dependent on when we get actual doses of vaccine. And we are not responsible for that. We are being given those vaccines by the federal government. So it's not like anyone's sitting around going, hey, did you call to see if we get some more vaccines? They're being sent to us, but we can't control those numbers. And hopefully after January 20th, we'll have people in place who really are focused on getting those vaccines out to us. But anyway, so that's the first phase. It's healthcare workers and then people in the most vulnerable positions for death. Phase 2 is individuals with comorbidities, 2 or more comorbidities, 2 or more serious conditions, and people over 75. And early education, transit, K-12, grocery store workers, utilities, all of the essential workers that aren't in healthcare. Adults over 65 are in phase 2, and individuals with 1 serious condition. And then that, all things being equal, working would probably be around February to April or through April, and then from April to June, the general public. So again, this timeline is subject to change. There is the enormity of getting this vaccine out is enormous. It is not like a flu. It takes, just simply around the vaccines that we have for us right now available to us, one of them takes a minus 90 degree temperature to keep it active. Everybody needs 2 doses. And so you can see how just that alone, the logistics of that, and those 2 doses come weeks apart. So just the logistics of making sure that those 2 pieces stay in place presents an enormous challenge for our public health system. So that, I think, is really in a real quick nutshell what the state has done. And I think I'll probably stop there and let the other speakers weigh in. I will say one thing, and that is that we are preparing for this vaccine, and it's vitally important, but we cannot stop our vigilance. We must continue because of the rollout and how long this is going to take through nobody's fault. We still need to continue to be vigilant, to wear masks, to social distance, to wash our hands, to take this virus very, very seriously. The vaccine will help us in the long run. It will get us through the dark tunnel, but we have to do our part and stay vigilant while we're rolling out this vaccine. So just because it's here doesn't mean we can stop doing the important work of staying safe. So with that, I'll pass it back to you, Eileen. Thank you.
Okay, thank you, Cindy. Okay, so our next speaker is Dr. Matthias Walz, who's a professor and chair of the Department of Anesthesiology and Perioperative Medicine and co-chair of the Critical Care Committee at UMass Memorial Healthcare. And he's been on the front lines of all of this. And he's going to speak about the medical issues and his observations through, I guess now, 2 surges, patients and patient care. Dr. Walz.
Thank you very much, Eileen. I would like to start by thanking the League of Women Voters for the opportunity to join this important forum today, and Senator Friedman for the kind comments that you have made. And I would like to echo some of those sentiments. The work that has been done on a state level to support the healthcare systems was instrumental for us to mount an appropriate response to what is an enormous challenge. And in many ways, we were one of the hardest hit areas in the world in the Northeast in the spring. And in many ways, the challenges we're facing right now tend to be even a little bit more complex than what we have seen in the spring. We are a safety net hospital at UMass Memorial Healthcare, certainly a UMass Memorial Medical Center in central Massachusetts with a very large catchment area. around 1.2 to 1.4 million citizens here in Central Mass, and have seen up to this point around 6,000 inpatients with COVID-19 and over 10,000 outpatients with COVID-19. So we have been indeed very much at the front lines of this pandemic response. We, in the spring, stood up the first field hospital in the state, the DCU Center in Worcester, which at that time at peak occupancy was set up to accommodate up to 200 patients, however, never saw more than around 35 patients, I think. We closed it over the summer. It's open again, and we already have close to 70 patients in there today, many, many more than we saw in the spring, and fully anticipate that the occupancy will go up to at least 100 patients cared for in the field hospital. If you look at the numbers in central Massachusetts of patients positive for COVID-19, we have already far exceeded the numbers that we saw in the spring, with over 350 patients as of Monday in Central Mass positive for COVID-19, and a significant proportion of them in the intensive care units. The one thing that is a little bit, there's a number of things that are a little bit different this time around, in that the ratio of patients requiring hospital care but not progressing to critical care is a little bit higher than in the spring. In the spring, we saw a 2-to-1 ratio of patients on the floor, even a 1-to-1 ratio at times of patients on the regular floor and in the intensive care unit. We have 102 adult critical care beds at baseline, and in the spring had to ramp that up to 155 beds in critical care. So 150% of baseline capacity, which was an enormously heavy lift for the system. And we are truly appreciative for the support that this healthcare system has received on a state level. This time around, the ratio between patients requiring care on the regular floors versus the intensive care units is more 2 to 3 to 1. So a little bit less burden on the critical care providers and more burden on the hospital medicine teams, and how we create the capacity to accommodate all of these patients. And we believe, nobody has a crystal ball, that unfortunately, you heard Eileen mention the numbers earlier. Massachusetts sadly broke a record yesterday with over 7,100 new infections in one day. We anticipate through the remainder of this month those numbers to go up further, and for us to having create more capacity. So it is imperative that we do not let our guard down. Maintaining our workforce, as Senator Friedman has alluded to, is a formidable challenge at this time, a little bit more so than in the spring, where it was really the states on the East Coast and West Coast that were hit the hardest. We had access to additional caregivers and healthcare workers from the rest of the country. This time around, that is a little bit different, in that the whole country is struggling with their infection rates of COVID-19, and there are no temp workers to be had anymore, a very few of them certainly, which really makes us dependent on our own labor pool. And I can tell you that one of the differences that we see from now to the spring is that many more of our caregivers, unfortunately, are coming down with COVID-19 this time around than compared to what we had seen in the spring. In my department, the anesthesia department, which spans all of UMass Memorial Healthcare, around 220 people on the team, we had 0 infections for a period of 8 months through the spring into the summer. And we already have had over 10 patients in the span of the last 8 weeks. 10 employees over the span of the last 8 weeks turned positive in our department, and for the healthcare system, that number is certainly higher. The acuity that we saw in the spring, certainly in critical care, was something that none of us had ever seen over the span of our careers outside of combat zones. We have learned to deal with this disease a little bit better. We have more effective therapies available, and the mortality rates and case fatality rates associated with COVID-19 fortunately have come down. We know how to treat this effectively a little bit earlier, but the sheer volume of patients is absolutely concerning. And just because we have more effective therapies available to us does not mean that we're in a place where we can lean back and rest on our laurels. The death rates remain absolutely staggering, just by virtue of the sheer numbers of infection that this entire country is still experiencing. And we have got to make sure that we keep ourselves and those around us absolutely safe. we appreciate the support of our communities. We are now in a position where we have to slow down non-COVID related healthcare to make sure that we can maintain the labor pool to care for all of our patients. And that has an impact to all of those who seek healthcare unrelated to COVID-19, who have to delay care that is needed, maybe not emergent, but needed. And that has to be postponed a little bit into the spring. All of the healthcare systems in the state now are at a point where they have to create what we call surge spaces, where we can accommodate both patients requiring care on the regular floors and care in the intensive care units. And we have to pull caregivers from those areas that would ordinarily accommodate patients with non-COVID related healthcare issues to really, for the next few weeks, focus very much on COVID, and certainly focus on getting all of our first responders vaccinated as swiftly as feasible, dependent on the supply of vaccines and availability of vaccination slots, to make sure that we can maintain the integrity of the workforce. And the challenges there are profound. Some of our caregivers have been involved at the front lines since March. And the emotional burden and the drain and the strain on our caregivers is truly enormous, the full impact of which I believe we won't be able to entirely gauge until we hopefully have been able to put this pandemic into the rearview mirror. So what is the time frame that we're looking at? I think hospitals will hopefully see the height of this surge going into early February. Our prediction and the predictive models that we're looking at on a state level would suggest that we may be able to come off this plateau towards the second half of February going into March. And once temperatures warm up outside and people can venture outside, we are extremely hopeful that we will see the rate of infection drop as a result of the ability of people to venture outside and not be inside and exposed to the risk of infection. The full effect of the vaccine, remember, that is going to take much, much longer. This concept of herd immunity would require 200 million Americans to be immune to COVID-19, either because they went through the disease or they have been vaccinated. That is a formidable logistical challenge on a local, a regional, a state, and a federal level. And the full impact of the vaccination program we will see going into the next fall and winter, where hopefully we will no longer be confronted with the challenges that we are confronted with now. But in the meantime, as Senator Friedman has elaborated on, it is imperative that we keep each other safe, even if we had the vaccine. What the scientific community does not know with certainty at this point is whether the full complement of neutralizing antibodies after having received the second dose of vaccine, and I was blessed and fortunate enough to have received my second dose the day before yesterday on Wednesday. It was an uplifting moment. But we have to continue to wear our mask because we still might be able to spread the virus despite us no longer being susceptible to the full impact of the disease that is COVID-19. So even with vaccination, we have to continue to adhere to sound principles in epidemiology and public health and keep each other safe. We don't want to spread it to others, even if we can have a sense of comfort in the knowledge that we have been vaccinated and should not be prone to developing symptoms of severe COVID-19. So let me conclude with those remarks so we can allow for ample time for any questions that you may have. And let me express my appreciation again for participation here today, and to Senator Friedman and our state authorities in the immense support they have provided to the communities and to the healthcare systems. I can tell you that without the support of local and state, federal governments, UMass Memorial Healthcare alone would have incurred a loss of $200 million, which would essentially amount to a kiss of death. And with the federal aid and the state aid that we have received, we were fortunately able to weather certainly the first wave of this pandemic, and I'm very hopeful that the same will hold true, getting out of this second wave. So with that, I would conclude my remarks and thank you for joining this forum today.
Okay, thank you very much. And the next speaker is Casey Mellon, the health agent and interim health director here in Lexington. Casey?
Hello, and thank you for having me. Welcome, everybody. My name is Casey Mellon. I'm the interim health director here for the town. Unfortunately, David Nealon, our Board of Health nurse, isn't available. He's busy tracking and tracing, and I believe he has a meeting regarding cases and what have you. So he's unfortunately not going to be able to make it, but I can definitely fill in the need be. There's a couple of aspects I could talk about, but I think for simplicity, I'm going to break it up into two. First, a general update on the town and what I think is how the town is doing, and a little bit into kind of what the hot topic right now is, the actual vaccination of the public. So let me start with what about Lexington. Right now we have, as of the 6th, we have 742 confirmed cases since the beginning of this pandemic. The last 2 weeks, we've had 83 cases and 68 cases in the last week or so. Generally speaking, and I know this from talking with other health departments and just knowing what's out there, as a community, Lexington has been doing very well with this. We're still in the yellow. Our test positive rate is, I got to hear, it's like 2.83, which keeps us in the yellow. You need to, for a town this size, you would need to have a 5% test rate. We're fortunate. There's a lot of red around us. We don't get a lot of complaints about people complaining about businesses and situations. We certainly have some, but we've never had to come to the point where we had to fine individuals or threaten to close them down. My general impression is that as a community, Lexington respects this and is definitely doing their best, at the resident level to do what they can to keep the numbers down. So yeah, that's kind of my general impression of what's going on in Lexington as a whole. We are doing all of our tracking and tracing in-house. There is a good program with the state, but so far we've managed to keep that in-house. So most of the cases that come in, we call, I'm not myself specifically, although I am starting to learn that just in case we have a need. I'm starting to learn the system, but we have the two or three individuals doing that in-house. So anybody involved in Lexington will get calls from us. So that's kind of a general update of our opinion on how I think things are going in general in Lexington. I think they're going pretty well comparatively for a town of this size, this close to Boston. We're fortunate, especially from the work level. I mean, you just go to some neighboring towns that have triple or quadruple the numbers. There's smaller towns that half the size that have more cases than us, and they're in the red. So yeah, it's great that Lexington is taking this very serious at all levels. The next part I'd like to talk about, and I'm going to focus, is on we're getting a lot of questions now. We just put on the town news a new link regarding that. So we're going to start referring people to that, is the vaccination process. As the senator alluded, there's 3 stages. At the local level, we're going to be more involved at the last stage. We're not going to have a lot of involvement in a lot of these specific categories of phase 1 and 2. We will have some involvement. For example, next week, there are 4 communities, Lexington, Belmont, Arlington, and Watertown. They're holding 4 or 5 clinics for first responders. So they have about 600 vaccinations. They're going to plan it out so they all go at certain times. So no vaccine at all is wasted. And so that's one of the initial groups of people to be vaccinated, and that includes first responders, police, fire, and some of the dispatchers also. So that is one action we're being involved with. But for the most part, and this is a general statement, a lot of these earlier stages, it's going to be done through the medical side, doctor's office, hospitals, nursing homes, and what have you. A lot of people are calling and say, "Oh, I have this, this situation or that, or I may fall in that group." We're not at that level yet. We're more at the stage 3, where's the general population. It doesn't mean we won't have any involvement at the earlier stages, but that's kind of, as the senator alluded, we don't have that control. It's not like a flu clinic where we get a vaccine and we can kind of decide what we want to do with it. Do we go to schools or what is our needs? Public housing, whatever. We don't have that control. It's really, we have to go by the strict guidelines, and they're good guidelines, and the state has done an excellent job with this, but we do have to go with their process and what availability and what availability will we get. So as far as the planning goes, Lexington, we've started about 3 or 4 weeks ago, actually making a plan, a working plan to vaccinate the larger groups of people, the general population. So most towns have emergency plans already, but they're more geared towards what happened in the 2000s with large, short periods, one location, vaccinating a large population. Like the idea would be that, an anthrax attack, that, so that we have those plans in place, but they don't fit this kind of scenario. It's not a one size fit all. So we're making plans as we speak, having several locations throughout the town for drive-through, through walk-through, various locations, various numbers, because we don't know exactly how this will pan out. We don't know if we're going to get a big chunk of vaccine, whether we'll really have to be sure they'll have to be drive-through, or we'll be able to do walk-through. They both have their pluses and minuses and what have you. So we're doing that as we speak. We actually town actually hired a retired health director to be involved, and she will be taking up. I started a lot of this, along with fire and what have you, and she'll be taking a big lead in that and kind of finalizing those plans. That's kind of been the bulk of my work here in the office. Again, we have nursing, we have a nurse, and we have some staff that are doing a lot of the tracking tracing. I'm kind of on the other side of public health right now for COVID, plus your normal responsibilities for a public health office that still come into play, permits, questions, what have you. So I think this might be, I know my experience with these is a lot of times it's easier to wait for questions, because I could go on about the tracking, I can go on about the fining or the policies for complaints and all that. But I think with such a broad field, I think this might be a good place to wrap up, just because, especially talking about the planning of the emergency side of it and the vaccinations.
So can you just talk a little bit about the tracking before we go to questions?
Sure. When someone becomes ill, and the doctor can certainly step in if this is not my expertise. I do know the basics of it. Massachusetts has the Mass Virtual Epidemiologic Network. So basically, anybody that gets a communicable disease that's in the code, there's about 30 or 40 of those. And believe it or not, coronaviruses have always been there. So when this all happened, there was a code for quarantine, isolation, what to do. That there wasn't. It's always been there. It's just that we never had a pandemic of the scale. So when someone becomes ill or they're probable, they're in the system, whether it's from the hospital or their doctor, the tests. So they get the test is positive, they go into the system, and then we get notified here if it's a Lexington resident, and we call them up, ask them a series of questions, determine what their action should be, how long they should stay at home. And probably the key to this, and this is what you might hear nationally, what other areas don't have nearly the ability that Massachusetts has, is you can find out who else should be considered. That's really the key. If someone becomes positive and they don't track and trace, there might be people in their household or coworkers, and they work right next to them, and they're not part of the equation. So that's part of that. So that's really the key to the tracking. So that goes, so we ask all the questions, we determine, we check up on them, we give them any information that they would, or answer any questions they have. And then when their period comes out, they're closed out. And all of this is saved. This is all saved in the database, connected to, I believe, and again, this is not my specialty, it's also connected to a larger database for medical information. But Maven is the tracking system used for communicable diseases. And as the senator alluded to, there is a good state collaborate that if we weren't doing it, someone from the state would do it. And what happens is also a time frame. So if that comes into the system, and let's say it goes into a town XYZ, and no one's there to pick it up, someone from the state will take it within the 24 hours. So there's a lot of fail safes in there. It's not the easiest system. I mean, it's a good system. But there's a lot of fail safes in there to make sure that people are contacted and are part of the tracking and tracing process.
Okay, thank you. Okay, thank you to all the speakers. And now we're going to go to questions and answers. And I'm going to turn it over to Charles Hornick, who will be reading the questions. And then if we run out of questions, I have some questions. Okay,
Well, thank you. Thank you. And I do encourage people, just go to the Q&A function in Zoom, somewhere in the taskbar at the top or bottom or wherever, and feel free to type a question and we'll read it and our panelists will answer it. We do have a few lined up already. First, someone is interested in some testing strategy questions. Should someone get tested even if they have no reason to think they have the disease or have been exposed? Or is it better to leave it for people who have a more immediate need for testing?
That's a good question. Any thoughts from the on that? I've been hearing stories of issues where tests don't often are easily, because there's two kinds of, some testing is very conveniently located or easy to get to, like public we had 2 test clinics, for example. We had 2 drive-through ones. For something like that, that's convenient and free, depending on the town, ideally you'd want to hit the population that is most concerned. I guess that's a way to answer it. I mean, you do want to think about it. I mean, if someone's willing to pay the money and this place has a lot of vaccine, a lot of test kits and what have you, sure. But I think it's a balance of the ones that are more available kind of being used for a better target population, in my opinion. I don't know if that answers the question, but I don't think it's a bad thing, but I think, ideally you'd want to, if someone's more concerned and it's harder for them to get that test, that they at least get the ones that are more available, that are they're offered.
Thank you very much. Dr. Walls, could you just also answer that question, especially because we know that there are quite a few people who are asymptomatic or pre-symptomatic after exposure?
Yes, thank you very much. So the way we have handled testing thus far, and it partly due to some inherent limitations as to how much testing can be conducted early in the year, that was due to supply chain issues, the appropriate testing media, we have really been focused on testing those with symptoms or those with exposure. And then the third category of individuals in the community who were subjected to testing were those who were scheduled for elective surgical and procedural care prior to coming into the hospital, because we know that there can be asymptomatic spread. So I think it's really focused on that rather than testing the entire population. Now, we know that there are countries who have employed that type of strategy and they have been pretty successful with it, but there are inherent limitations and constraints that we are dealing with. So we believe that the most valuable strategy is to really focus on those who have symptoms, have had known exposure, or have to present to the hospital for hospital care to make sure that they're not asymptomatic spreaders and then, unbeknownst to us, disseminated inside the hospital to caregivers and other patients.
Okay, thank you. Cindy, do you have any comments about that?
Yeah, I mean, I think this is definitely a discussion that's gone back and forth and has been, debated by thoughtful people. I guess I would say that because there are so many people with asymptomatic, present asymptomatically, that it is especially important that we ensure that people in high risk communities get access to testing. And I think that's what the state has tried to do. And the healthcare bill that we just, that was just signed into law that we passed actually allows for asymptomatic testing at no cost. So, and that is not in place yet, and the state will come up with some regulations. But I think it's a fine line, we're walking this balance between, and I think people who aren't able to stay at home or work from home or whatever, and live in high risk and very close communities, I think we should encourage people to get tested.
Maybe I can add to that UMass Memorial Healthcare has actually set up a testing site in Marlborough where we have been able to offer testing at no cost to asymptomatic individuals. And that testing site is very, very busy to the extent that we can do it. I just don't want to be misunderstood. I think it makes absolute perfect sense. once we get into a situation where there's constraints in the system, it kind of forces us to focus on the higher risk parts of the population, as Senator Friedman has alluded to.
Okay, thank
Yeah.
you. Charles, now the next.
Yeah, we have a whole bunch lined up here, so we'll try to keep moving. What is the role of antibody testing in fighting the disease at this point?
Dr. Walls?
Yeah, not really. It's from an epidemiological standpoint, it is helpful to better understand what parts of the population were exposed, but it's kind of an after the fact understanding of who is likely to have had the disease. We remain dependent on the more precise molecular testing that can show us active infection to make sure that we mitigate the spread of the disease throughout the community. So while there is a role for antibody testing, that is kind of an after the fact testing that is more important from an epidemiological standpoint to say how many people really had it. You know, this tip of the iceberg question, where do we really know how many people have had it? You know, if you systematically test the population after the fact, then you get a better understanding actually how far and widespread the virus was.
Okay, thank you.
Okay, next is for Senator Friedman. Can the state's contact tracing program handle the current large number of new cases?
It is really yet to be seen. Okay, I think contact tracing in theory is incredibly important and very useful when you can do it very, very quickly. But there are lots of barriers to this, okay? And I think this is where we see the real gaps in our system, in our economic systems and in our housing systems and our healthcare systems. I think that the contact tracers have a big job when you call somebody up and, when you're told that somebody has the virus and you call them up and say, okay, well, who have you touched? Who have you seen? Who have you been with? And you're talking to people whose livelihoods, whose ability to keep their, to keep shelter over their head and food on their table, are very reluctant often to say, yeah, go talk to this person. And here's my family and here's all the people I've been in touch with. Because if you do that, you run the risk of being unable to take care of yourself. And I think a lot of, contact tracing is good and it's important and we should have done it. And it took a long time for the state to really have a robust system in place. But we also have to deal with the fact that people are really worried about even talking about having this virus because they lose their ability to take care of themselves. And it means they may lose their jobs. It may mean that they don't have rent anymore. And because we have no safety net, because we are so dependent on our employers and people having jobs to stay healthy, it's a really big task. So I don't know if we're up to it. And I think it's a concern. And I think that's why we have to get the vaccine out as fast as we can. And we got to keep people with masks and hand washing and social distancing. And the state has to be more proactive about ensuring that people can remain healthy, but also have enough money coming in to put food on their table.
Dr. Walls, do you want to comment on that?
No, I think Senator Friedman really captured all relevant aspects of the question.
Charles?
Okay. Sorry, Mr. Mellon, did you have something to say?
Yeah, I'll echo that. I mean, people are hesitant. Some people will tell you everything when you call them, and some are very hesitant to give out information because, as Senator alluded, there's the safety net really isn't there, and that's been a topic that just doesn't get the attention in this country, that we can't give people a chance to quarantine or do things safely because they lose their insurance or they lose their job, or that's really a story that really it's sad, but that's the reality of it. So, the tracking and tracing is very key. but it's not 100% perfect. It's like anything. It involves the involvement of the citizens and residents. If they're on board or they're not worried about the financial aspect, they can cooperate. If they are concerned, they won't give all the information. There's nothing we can really do about that.
Okay, our next question is about the availability and usefulness of home testing.
Yeah, so maybe I can take a stab at that first. So there is an enormous amount of research and development being poured into the development of reliable and affordable tests at the point of patient care as well as at home. UMass Medical School just received the largest grant in their history, $120 million from the NIH. The principal investigator is Dr. David McManus, chair of the Department of Medicine here, to really accelerate the development of affordable and accurate tests that can be not only delivered at the point of care and markedly shorten the turnaround time, which is obviously, that's often a challenge that we face in the healthcare system, right? The time from when the test is delivered to getting the result back, to not only accelerate that time frame from doing the test to getting the result, but also make it much more widely available, including the home use. So at the current pace, looking at the enormity of the resources that are being poured into the effort and how hard industry is collaborating with the scientific community, I would not be surprised if we saw that before the end of this calendar year. I can't know for certain, but I can tell you that there is a really wonderfully comprehensive and concerted effort underway on a national and international level to make that available.
Thank you. Charles?
Okay, next, how do because the question is, what is the place of schools in all of this? How do schools play into the whole testing and so forth?
I'm not sure. Not really know if I'm the best one to answer that. They got their own set of, they're related, but they do have their own guidelines, both at the state level. It's a bit of, that's one was definitely where there's some politics in that one. That we keep it, well, one thing, we keep in contact with the schools pretty much daily. So we definitely overlapping as far as the tracking and the discussions on what's going on with any positive cases and what have you. And LexMedia is doing well. It is, I'm sorry, what is I'm getting off topic here because what's the original question here?
Well, sorry. I think the actual words were, could you address the status of schools in all of this?
Well, they're in hybrid. I mean, they are continuing and planning on staying in hybrid. We don't have direct, we can make recommendations and discuss that, but that's ultimately up to the school system, whether in the state, whether they can't go remote or decide when to take periods of time off and what have you. That's really, they're kind of their own animal in a way.
So Cindy,
yeah, go ahead.
At it in different areas in your district?
I'm not sure what you're asking.
Oh, I mean, I wanted you to just answer the question.
Okay. So I mean, the schools, okay, in terms of the people who work there, are part of the essential workforce, and they are part of the second phase. This is part of what the advisory committee had to struggle with. This is such a difficult decision when you're saying who should get something first. When you put a priority order together, it's, what you're saying is this group of people or this set of activities is more important than this set of activities. And it's not like everything isn't important, right, in this case, because it is. What I think we've looked at is what is the overwhelming responsibility first and foremost, and that is to stop people from dying. And so that's how these priorities were set, okay? And so when you look at essential workers, they are essential, and the numbers say that if you're over 75, you have 10 times the likelihood of dying, right? So you set up these priorities, right? And remember, lots of people are in different, in different phases. So for instance, if you're a teacher and you have two existing serious conditions, you're higher up than the essential workers. You're going to get the vaccine first, okay, or before the 29-year-old teacher that's really healthy, okay? Is it important to continue children's education? It is absolutely important. It is one of the most important things we can do, right? But if we don't pay attention to people that can die, there's no coming back from that, right? Kids may lose a year, they may lose a couple years. It's really serious when that happens, but it's not as serious as dying. And so that's the roles that school play, is that they have to keep their staff, their teachers, they have to keep them safe while we're working through this. And whatever that takes is what they need to do. And it is not easy. And listen, there ain't any good decisions in this. There's no, this is the good decision, this is the bad decision. We're making decisions, we're making the best decisions around bad options, okay? So the role the schools play is to keeping people safe, work on their ability to provide education in other means besides in person, incredibly difficult. But in the meantime, we're going to roll this out, and we're going to try and take care of the most vulnerable first, and then keep getting people vaccinated. I don't know what else to say about it, right? And I think people need to just understand that these are life and death decisions that are being made.
Thank you. Charles?
Okay. Next one is two related questions. It's about how to talk to people who either refuse to wear a mask or who deny that COVID-19 is a disease. Maybe it's for Dr. Waltz.
Yeah, that is a question that I have been struggling with personally. I'll be very honest. When I walk into conversations where people say, "Well, it's just like the flu," and it goes back to what I said earlier. If one had the ability to take people to the front lines and show them what the face of this pandemic really looks like, I think their stance would change in a hurry. But for obvious reasons, that's not possible. I think this really is centered around the concept of individual freedom, and the way I would frame it personally is that individual freedom is incredibly important, up to the point where the way we exercise our individual freedom impacts the safety and well-being of those around us. And I think that there are unfortunately, this has become very, very politicized across the entire country. And these conversations are challenging, and I don't think there's one good recipe as to how we would approach this, other than trying to shed light on the fact that our choices and the decision we make for ourselves, certainly in the context of this pandemic, can have profound and sometimes deadly impact on those around us. So who do we want to be as a society? And I can also share with this group that the data on the impact of politics on public health is unequivocal, and that impact is profound. In other words, how we lead by example, how we communicate around the threats and the dangers of this pandemic, how we communicate around the value of public health has a direct and tangible impact on how many people get sick and how many of them die. This is an uncomfortable truth, but it is a truth nevertheless that I think is important to understand. So I think we need to be respectful of each other's opinions, but at the same time really try to focus on how can we best support each other, and how as a society can we make sure, now that there is light at the end of the tunnel, our collective responsibility is to make sure that everybody makes it through that tunnel, right? And again, I'm not sure I even answered the question with tangible information or recipe as to how to approach it, but those would be my thoughts around the question.
Eileen, I just want to follow up with one thing that the doctor said, and he's absolutely right. I also would like to point out to people, and I think this is possibly useful. we have all sorts of public health rules that every single person follows every day. You're not allowed to walk into a store in your bare feet. Restaurants are not allowed to keep cold food out on the counter for more than a certain amount of time and serve it to you. You're not allowed to do a number of things because of public health, and that has always been true. And we've never taken away anybody's liberties. You can stay home, right? But you can't do certain things for purely public health reasons. And just look at, you can't walk into a store without a shirt. That's a public health. That's a public health rule. It's not we don't like your shirt, right? And so we've done that all the time. And this is just another example of what we do as a society to keep people safe. And if that's a real problem for you, which I absolutely will respect, then you can't come into the public health space because we can't protect everybody. So this is nothing new. We didn't come up with some brand new set of rules, right? I mean, yes, the individual rule is different, but we've been doing this forever. So I also often point that out to people, that this is not expansion of anything that we have been doing.
Thank you, Charles. And Charles, also, there are two questions in the chat. I think they're coming from people who don't have access to who are on the phone. So if we could take those questions as well. But
I'll handle that. This is questions, I think both of these are for Mr. Mellon best. First of all, I believe this is about vaccination, does phase 2 for the state correspond to phase 2 in Lexington? And are there any things different about how Lexington is handling phase 2 than the statewide guidance?
No, we can't. We pretty much, as I alluded to earlier, we have to go by their guidelines. There's not a lot of flexibility. It's not like we can kind of choose one group or what have you. So the short answer is no. As a matter of fact, the link that we just put up on the town news is from the state. So the short answer to the first one is we're going by what the state is requiring. The second question, it's a little more complicated. Again, the schools are their own animal in a way. The state, I think about maybe 3 months ago, set out their requirements and guidelines for the schools regarding COVID. Now, the state does get involved. I understand, they'll tell a school system, for example, is like, you're remote, but because of your numbers, you should be hybrid, and vice versa. So the state does have a lot of authority in that, but I have heard that there's always a bit of pushback. And again, when you're dealing with the schools, and I don't want to get too much into it, you got various groups. You got you got the parents wanting this or that. You got the school administration. You have unions and safety of the employees. So there's always a bit of pushback around with that. But there are regulations from the state, and they do weigh in. Whether it's 100% they make the decision, I don't really know, or I don't think so. But they do weigh in and say you should be open for hybrid, or you should be closed based on the information that's out there. I'm not really the best one to answer this question.
And next for Senator Friedman, other states have rolled out contact tracing using cell phone apps technology, the possible exposure technology. It was developed by Apple and Google. Why has Massachusetts not taken this route?
That's a question I can't answer. I don't know the specific details of the contact tracing, and I was more up on the information when we started in March and April, but I really haven't been involved in it since then, so I can't answer it. Sorry.
The only thing I can weigh on is that everybody that gets a vaccination is going to have a specific card. And the state now, this is hot, kind of hot off the press. I believe as of last week, they're going to be using a program, Prep Mod, which I'm not too familiar with. It's been around for a while, but it hasn't been really used that much. But the key is whatever they do, they keep it consistent. So everybody's going to get a card no matter what system they're using to verify. They'll need that to verify that they've had the shot. And it all needs to go into the correct database consistently. So we have records of that. I'm not really familiar with the apps. I've heard rumors about apps, but I don't know much about the subject either.
Maybe I can briefly add to that, that the introduction of those apps, as I understand it, has not been universally successful either. There's mixed results produced with the apps. And as it relates to healthcare systems, we do report to the state on a daily basis our symptoms with apps that all caregivers have on their cell phones. So every morning when we come in, we do use that app, report to our healthcare system, and in turn, the healthcare system reports up to DPH about presence or absence of symptoms, presence at work, or staying at home. So to an extent, certainly in the healthcare space, these apps are being leveraged.
Okay, and I do ask that people do the questions through the Q&A function because it lets us keep them all together in one place. But there is one in the chat, which is, and I think this is for the phase 2 vaccinations. How would you find out when and where you can get vaccinated if you fit into one of the phase 2 categories?
The state has a very, and I give credit to the state. They have an excellent setup and websites for the information. As a matter of fact, they have a link. I mean, it's just started up, I believe, and they're going to start to populate it. Is you type in, where can I find shots, and it'll start to list locations. And I think one of the things, and I don't know if I mentioned this early on, especially with those earlier phases, it is going to be more on the medical side of things. Your doctor office, or the nursing, or what have you. But there are links online that are being, that are starting, that will give information on where people can potentially get vaccinations. And we're going to be updating that here in Lexington on our link, adding what's going on more specifically to Lexington residents, and of course always deferring to the state website about vaccinations.
Okay, that's all the questions. I do want to give people a few minutes. If you have a last minute question you want to type in the Q&A function, that would be great.
I have just while we're waiting for other people's questions, and that is, sure. There's been a lot of concern about these new strains and whether they are covered by the vaccine, the existing vaccine. So Dr. Walls, could you talk about that and what we know and what we don't know?
Yeah, thank you very much. I'm equally worried about it. And this is the strain you're referring to that was first reported out of the United Kingdom. Where just for frame of reference, the level of genomic sequencing, as we call it, of the genetic makeup of the strains of viruses that are out there are much closely monitored in the UK than many other European countries or the United States. The scientific manuscript is being submitted for publication now, but what we know is that the evidence is pretty hard that this strain is much more contagious than previous strains, but does not appear to cause more severe disease. Furthermore, thus far, there is no indication to suggest that the vaccines that have been approved for emergency use authorization by the FDA, that is the Pfizer and the Moderna vaccine, are any less effective against that newer strain of virus. Now, at the same time, I think we also know that that virus is here in the United States. The first cases were reported out of Colorado, and when the health officials there did the contact tracing, there was absolutely no connection to any travel overseas, which would suggest, which I fully expect, is that that strain of virus was here in the United States for some time. And if you ask me, why do we see so many more healthcare workers infected now than we did in the spring? Maybe emotional depletion, pandemic fatigue, and behavioral patterns are one explanation. Personally, I'm concerned that a more contagious strain of virus may be another aspect of the explanation. And if that holds true, it goes back to what I said in my remarks at the beginning. We are going to see the numbers of cases go up before we see the plateau. So it's concerning, but the two pieces of reassuring knowledge that we have: number one, it does not appear to cause more significant disease. And number two, it does not decrease the level of effectiveness of the vaccines that are approved in the United States, which currently is the Pfizer and Moderna, both messenger RNA vaccines that are being rolled out.
Okay.
And maybe I can add to that, that now we talked about schools, and I have a lot of opinions on that, but the good news is that the Moderna vaccine, which this is a company out of Cambridge, here in Boston, is now rolling out their pediatric trials. And in fact, UMass Memorial Healthcare will be one of the sites where we will be enrolling children. I hope my 12-year-old will sign up for it. I have 3 daughters. The older ones are 18 and almost 20. But from 12 to 17 years of age, Moderna will enroll pediatric patients, and that will start certainly here at UMass Memorial Healthcare at some point next week. The IRB gave their approval to move forward with that, and I think that's a very important next steps as we think about schools and how we handle that to get our kids vaccinated. It is incredibly important for their emotional, social, and academic well-being to be able to go to school. It certainly cannot be at the expense of loss of life somewhere else in the equation. But to the extent that we can build systems that safely allow for that, I think there has to be a great deal of focus on it.
Okay.
And I'll add one question actually of my own, are we likely to be seeing the other vaccines that are in late stage trials or have been approved elsewhere, like the AstraZeneca vaccine, appearing in the United States anytime soon?
Yes, so great question. So the clinical trials that are required to bring a vaccine to market are separated in 3 distinct phases, and the phase where we give it to patients and determine their efficacy is what we call a phase 3 clinical trial. Phase 2 is really to determine, phase 2 and 1 are more focused on safety of the vaccine. There were, at the time that the Pfizer vaccine, which is the collaboration between BioNTech from Mainz, Germany, and Pfizer, underwent emergency use authorization in late December, there were 12 other phase 3 clinical trials underway. I think AstraZeneca is the furthest and just received emergency use authorization by the European authorities. So that is now also being offered for vaccination, as is Moderna, I believe, in Europe. AstraZeneca, I have to be honest with you, had a rocky start with the FDA and how they shared data, and there were some concerns around their clinical protocols. I think the fact that they're approved in Europe now is going to be helpful. I think Johnson & Johnson is very far down the road. I think the aggregate number of candidates in the pipeline is somewhere close to 50. And that is important because some of these vaccines are incredibly expensive and will not be suitable for dissemination in developing countries, which is obviously a major concern, not only from the perspective of health equity, but also in order to get control of this worldwide pandemic. But I think eventually we're going to have 10, 12 in quick succession viable candidates for vaccination. Some of them more expensive, those would be Pfizer, Moderna. Some of them less expensive and easier to store, like the AstraZeneca vaccine. And I think the Johnson & Johnson vaccine, if I'm not mistaken, I may be wrong on this, only requires 1 shot, not 2. AstraZeneca also requires 2 distinct vaccinations.
Okay, and we do have one more question that's related to one that was asked earlier, which is how will we find out when the time has come that we can be vaccinated, that any given person can be vaccinated?
I think.
Sorry, go ahead, Casey.
I think for a resident in Lexington, the easiest at this point would just be to just refer to the website I referred to, and I believe you can register for email updates for townwide news. But obviously, I'm assuming that this question is more for the larger events for the general public, and we'll do whatever we can to make sure residents are aware of what's going on with that. For sure.
That's all we have for questions. Eileen, if you'd like to wrap things up.
Right. Yes, I'd like to wrap things up. I want to thank everyone who attended. I'd like to thank our 3 participants, our State Senator Cindy Friedman, Dr. Matthias Walz, and Casey Mellon of the Lexington Health Department. Thank you all for being here. This has been recorded. It will be available on LexMedia. I think it was an excellent summary of where we are, and I appreciate all the people, all of our panelists, and also all the people who listened in today. So I did also mention at the beginning our upcoming league events. So our next First Friday, they're always First Fridays, and before the pandemic, they were always in the Carey Library here in Lexington, but now they're all on Zoom. Is Friday, February 5th at 9:30 a.m. And Carol Rose, the executive director of the ACLU in Massachusetts, will be giving a post-2020 election review. And also, the league is sponsoring a candidates night for our local elections on February 11th, 7:30 to 9 p.m. Also available on Zoom. And if you just Google League of Women Voters Lexington, you can get all the information and the Zoom link. So thank you, everyone. Thank you to all the participants. Thank you, people who are watching. Thank you for Charles for doing the technical aspects, and to the League of Women Voters for making this possible. Stay safe, wear masks, socially distance. Thank you all very, very much.